Mitro kakamio, minero kakamio, kakamiampo kwa mwasi anansio. Adam sesere kusi anansimuno mfe. Nansimuno mfe.
Namba no ntimi di. Ntimi mena duane awuni. No fon kwa na no no. Na me so e ha me. Se nkakra de wanya wan ya de de anka betime di kuku kakra. Enso so me man bibia no woni. No fon kwa na ma me frɛ. A me frɛ no mu kire se enye hwe. Enye yawe no yawe. Ba kra bi wo ho asa na otie. Enti se menya kontomira anase binsia. Ifanya bu mu kakra ma no. Na me for so no se obedi e no so kakra no so betimi aboa me.
A couple of years ago, we identified the fact that Ghana's use of mobile phone was on the increase. In fact, at the time, the rate of use of mobile phones was nearly 2 mobile phones to 1 person in Ghana. We wondered what that could impact on child survival, especially in hard-to-reach areas of our communities. This prompted me to ask a very basic research question. Could mobile phones be used to improve child survival, and how can we do this? So I came up with a concept of, ensuring that all those mothers who would wish ordinarily to access healthcare, but for some reason were not able to access healthcare, that we utilize the medium of mobile phone usage, including all these hard-to-reach areas, and assist mothers to call into a system that gives them a certain algorithm that we have prefabricated within the system. So basically, mothers with children who suffer febrile illness and complications of febrile illness would call into this system that has been designed with the local contractor or consultant. And what the idea is that the mothers call in, the system then shows them what to do. And on the basis of the symptoms and the signs that the children would have, the complaints that the mother will have from the child, they will be directed as to what actions to take.
Nachi bakwa nasi nachi minu echimu no microphone efrem so obra on kanche mu krampo ana etisen ye pisi hu obebisa omo questions bibro obebisa na moyi anu amano why sima be dubi ni ebie nipa baako bia why
nipa to oba yare po
bacha
oba yare a obeden no hu se mebe oyare onti apo
bacha me mana me pagropa nti se me hu se waye din a na obi o so na we susu na me hu se bibi e de ha na bi o so na ho hye timi gina no so na me hu se me be no bia ho fa
okay nti sa efidi e ya de a obe ka kire obi a ebi ono so kom ha se eye na onyi su ana
manfa challenges mubia na me kra no na munya man kwa medical bobo ma me na o mtia man ye sabe na ba ne ye papa to bi anfa no hye medical akra ka kire o mu just na ne use but unim the system a wa ha so far uguta ida ikra say insurance but definitely utia but because of some MOBCHILD I don't know some no more connection bi dia mint but nya koduru ne complain kire o mo say o ase ene munya ini edi ya nkita hodie bi ɛna maa yɛde akwalaa ne baa ya ɔmo nkyaaje bibia no aso ma akwalaa na ne yɛkɔ
ɛna MOBCHILD ni sɛ me kunu ni hɔ a na sɛ me ba ne yale ya metimi afa number no ɔmo number ne wɔ mo sɛ ka nyɛ fon asɛm na me ni dia na sɛ me wɔ fon no ko ade a metimi aflɛ na sɛ mo ma me nkyerɛ bi sɛ me fa akwalaa no kɔ hospital metimi de ya metimi de na kɔ sɛ sika ni me wo kra na sɛ me kɔ a metimi ayɛ de ɛde na kɔ na sɛ akyire na sɛ ɔno so enya bia wa yɛ de ma frɛ na ma na ba bɛhyɛ abɛboa yɛ ne akwalaa
me use phone na me kwa me nya adagye ekyerɛkyerɛ no sɛ ne obesi ɛbɛbɔ number no sɛ de obesi afrɛ sɛ de wo frɛ a time a wobetimi abotire a wobenya ɛne nipa no kɔpem sɛ doctor ɛbɛ answer phone no time a wɔsɛ wunya de wɔsɛ woje because so nya wo frɛ direct na doctor apeke wɔsɛ wo ne doctor wo train kakra etie use language a ɛbɛboa wankasa ne nyinaa ɛyɛ kwan a na ɛfa so ɛboa awofoɔ no bebree nti obi wɔ hɔ kwa na ɔno ankasa ɛni ne personal phone but yɛfa ɛkwan bi so ɛboa wɔm sɛ de bɛyɛ a ɔmo betimi ɛne doctor akasa time bi a ɔmo pɛ sɛ ɔmo ne doctor kasa nti obi wɔ hɔ kwa sɛ na bɔfra ne yare a na sɛ bi a oni phone na sɛ phone man na etimi kyɛn sɛ e bi a wotumi ɛyɛ sei ana sɛ woyɛ sei ansa na wanya doctor ɛne na kasa.
When it gets to data, we have a book that we normally take their records into. So because of that, it has really helped us to plan, especially when we are going for drugs. You get to know the cases the under 5 has been reporting to the facility. By so doing, you also know the type of drugs you have to go in for and then how to educate them during your normal routine home visits and all that. So for the data, it has really helped us. We have a book, we record everything inside, we know their daily conditions they come to the facility with. So.
It has helped us so much in identifying our challenges as a district and even placing that based on this particular what do you call it, the platform. We're able to see where some of these conditions are coming from. We have used that as a yardstick to even write for proposals for support. Okay, and I mean it has been very useful.
So MobChild, which is an acronym for Mobile Health for Child Survival, was conceptualized to address the issue of data unavailability at the lower tiers of the health system. Data is actually vital for planning health activities, but this is really not available for planning purposes. So MobChild was conceptualized to solve such problem by making data readily available to the district health management team and also to the health facilities within the district for planning purposes. So the idea is that we hypothesized an improvement in child survival when this system is used. So this is how the system works. A mother picks up the phone and dials a number on her mobile phone. The number is actually 0800 711 711. After dialing, the mother would receive a prompt in the form of a voice message that what is wrong with your child. If, for instance, your child is suffering from fever or experiencing fever, press 1. So the mother will, need not to talk to the system. So all she has to do is to just press the mobile phone, the numbers on the mobile phone, and indicate. So that would represent, or that would be an indication of whether the child is having fever or having diarrhea. So the system would ask the mother to indicate whether if it is fever, press, for instance, press 1. If it is no, press 0. So once the mother is able to do that, the system is able to pick these symptoms. So the system was designed to actually pick data on common disease symptoms experienced by children under 5. So this is the concept. That's how we conceptualized it and implemented it as a pilot in a district called the Asante Acheampong district. So currently we are in the final phase of the project. So what we did was we had an intervention arm and a control arm. So in the intervention arm, what we did was to implement the system, have the system in place where selected caregivers would access the system and seek reliable health information in terms of what to do to the child when a child is not well. So the system is able to provide recommendations to the mother as to what to do. At the same time, the system is able to pick important, relevant data, which is always useful to the district for planning. So by so doing, the system is able to provide data in terms of the number of children experiencing, for example, fever, the number of children experiencing, let's say, diarrhea, the number of children having cough. An important aspect of this project, which is worth noting, is that this project is an implementation research which basically seeks to improve current practices and bring about relevant change, positive change to health in terms of the child practices or child survival. So the change is expected to improve child survival as whilst the project is being implemented.
Caregivers who were part of the MobChild project were educated twice every week on 1, how to identify danger signs in your child, another on nutrition, where we gave several examples, recipes on nutritious diets that could be given to children when they are sick or even when they are not sick. And we did several interviews to ascertain whether they were getting the messages and how it worked for them. Many of them attested to the fact that these were very helpful in helping care for their children. We also educated them on healthcare seeking, because we found out that sociocultural norms and myths played a very major role in them seeking healthcare in this area. One of the things that we picked from the ground was their strong belief in seeking healthcare from Asram healers. So all these were part of our content. As well, we looked at messages that were already given to them in the child welfare clinics and added those contents to our messages. These were approved by the PI and the co-PI and were sent out to them, and they embraced them and attest to the fact that it helped them in caring for their children.
If I